When a woman stands up for herself, she stands up for all women. And all women go through menopause.
When someone like Halle Berry speaks up about menopause, it sparks a conversation that we've needed for a long time. And on the Menopause Manual, we are continuing that conversation.
I was at the doctor 3 days ago. I said to him, "You know why I'm having this issue, right?" And he says, "Yes, I know." I said, "Tell me, why am I having this issue?" He said, "You tell me why you're having the issue." I said, "No, you tell me why I'm having the issue." So I thought, okay, I have to do what no man can do. I have to say it.
Menopause affects millions of women, but it's often surrounded by silence, confusion, and stigma.
The shame has to be taken out of menopause. We have to talk about this very normal part of our life that happens.
We're going to break through that with Dr. Sameena Rahman, a Chicago-based OB-GYN, also known as Gyno Girl.
Hey y'all, it's me, Dr. Sameena Rahman, Gyno Girl. Guess what? It's Perimenopause Awareness Month. I want to say to those suffering that I see you, I know that what you're feeling, and I know the shame associated with it.
Whether menopause is on the horizon, already part of your life, or you're supporting someone through it, this program serves as a manual, your guide to navigate this natural phase of life with confidence. For all women, this life change starts with perimenopause. And perimenopause is often misunderstood because it looks different for every woman. Some breeze through it in a few months, others struggle for years. And the symptoms, they can easily be mistaken for something else, which can delay the care you need. Dr. Rahman explains this through a phase that she calls the 3 Bs. Let's just jump right in and talk first about perimenopause. What are the ages that usually starts to happen for people? I know it's a wide range.
Yeah, it's so variable actually. And if you think about menopause, the event is when you have 12 months without a cycle. So, and the average age is about 51 and a half in America. Perimenopause essentially means around menopause. So that could be 7-10 years before that final cycle. Some people, perimenopause is like months and they breeze through and that's it. And other patients really struggle for like up to a decade with hormonal fluctuations. I like to talk about the 3 Bs of perimenopause, which is what I refer to them as, but like the first one is always like bleeding abnormalities. So some patients will all of a sudden have this perfect 28-day cycle all their life, and then all of a sudden they're starting to have 21-day cycles, or the interval between the cycles is reducing, or they might even have heavier flow, which can really depend on a lot of things, fibroids, if they're ovulating that month, all the different variability. There can be change in the actual flow and the interval between periods. So that's the 1B. The other one is brain related, right? We have estrogen receptors from head to toe, joints, skin, inner ear, like you name it, there's estrogen receptors there. When it comes to our brain, there's so many cognitive changes and mental status changes or mental health changes for patients. The biggest one that I always hear about is brain fog and irritability. Like, I'm just so pissed off and I don't know why. Like, people are just angry for no reason. They're not getting along with their children, spouses, coworkers, whatever the case may be. So there's a lot of that mood disruption. And then there's like the brain fog, this like fear of dementia that we all have, and not being able to remember your words. I think that's the B portion, right? And then the 3rd B I talk about is burning. And so that could be the vasomotor symptoms, the hot flashes, night sweats, that type of burning. But also vaginal changes, like there can be some changes in the vaginal skin causing vaginal dryness, painful intercourse.
It was that 3rd B, burning, that led Halle Berry to share her story in Washington, D.C. Her doctor had misdiagnosed her with an STD when it was really perimenopause. That kind of confusion happens far too often. And beyond the common symptoms, mood swings, sleepless nights, there are others to be aware of. Symptoms like vertigo and even muscle and joint pain.
You all, I'm sure, have heard about my lady part issues. But menopause is not just about our lady parts. And so many people think it's just about what happens, below our belly button, and that's where our issues are. That's not true.
To Halle Berry's credit, she did talk about how she had really bad burning and pain after intercourse, and this was so bothersome to her that she was told that she had an STD instead of, really evaluating what's going on down there. But when we have these drops in estrogen, the vaginal tissue changes. It becomes thin, it shrinks in a little bit. The musculature changes of our pelvic floor. The outer part of the vagina, the vestibule, where you have to cross into to enter the vagina, changes. And that's because of the lack of estrogen and testosterone. So there are patients that suffer with like insertional pain with intercourse. They have vaginal dryness, a burning sensation, urinary frequency frequency, urinary urgency, a lot of symptoms that we kind of put into this term called the genitourinary syndrome of menopause. Some studies show up to 80% of patients at some point will have these symptoms. And it's a chronic progressive situation. So if you go and you're 10, 15 years out, it's much harder to get you back to the point where your vagina was 15 years ago, right? Like, so it's better to be proactive about it. And it's not really just about vaginal dryness or sexual pain. Urinary frequency, urinary urgency, and recurrent urinary tract infections are a direct result of lack of estrogen. When your pH changes in the vagina and you get a higher pH, usually our vagina is acidic in premenopause, and so it becomes more basic. You get bacteria that normally wouldn't grow there, really flourish there, and the changes in the urethra, where the little hole that you pee out of, also, is affected by all of this lack of hormone. And eventually, what happens is people develop these recurrent UTIs. Now, if you're 75 or 80 years old and you have a UTI, I think one of the statistics is, you have a 25% chance of getting septic, which means that you get, the bacteria in your bloodstream and you end up in the ICU. And I think like up to 6% of those patients die from a UTI. There's a whole host of other symptoms that you just never really hear about. I have patients who have new onset vertigo, or they just feel like the room is spinning all the time. I have a very common complaint for a lot of patients is muscle pain, muscle aches, and joint pain. One of our menopause colleagues, Dr. Vonda Wright, actually is orthopedic surgeon who was writing and really, being loud about the musculoskeletal syndrome of menopause. What is this new idea that my knees are hurting and they never did? Or why can't I recover from my workouts like I used to? What happens when you can't brush your hair because it just literally stops? There's all of these symptoms that can happen at any point in this time because of the perimenopause roller coaster, right? And I think that's where people struggle the most.
As hormones shift, women can experience changes in desire, pleasure, and emotional well-being, affecting both sexual satisfaction and mental health. Call it disconnected desire. When the want for intimacy is there, but the connection to pleasure is not.
One of the biggest probably sexual dysfunctions in midlife, like more than 40% of women have, is hypoactive sexual desire disorder. And that's low libido with bother. That means I want to have sex. I want to have sex with my partner. This is something that is not happening. I can't get myself motivated to do it. Or it's really is what makes you feel bad about yourself, you're frustrated, or you're having some issue with your relationship. A lot of that is due to fluctuating hormones. It can also be a lot of factors, right? You're a midlife woman, you're balancing kids, you might be balancing family, you're not sleeping, last thing on your mind is having intercourse, right? And I always say if it's the spouse or the significant other that you're having issue with, that one you have to extract on your own because no amount of hormone is gonna help that. You have this uptick in antidepressant medication at the time of midlife, between the ages of 40 and 60-ish. And really it's, like I said, when you have this decline in estrogen in your brain, all the centers that are modulated by it, estrogen modulates a lot of your neurotransmitters, and all of a sudden you might have these crying spells. People tell me all the time, I myself have had this, where you're just why am I crying for absolutely no reason? Even my kids are always like, is she crying again? Is this Peri, Mom? They call it scary Peri at my house. Mama, is this scary Peri or is this actually you?
You start learning about this at a young age.
Yeah, this is my 5-year-old girl. She's like, Mama, is this scary Peri? Yeah, this is scary Peri, Mama.
No, that's good.
But it's true. And it's really one of these things where you just, people get panic attacks all of a sudden they never had. All of a sudden they ruminate about things that they never did, and it's really a dysregulation in your brain, right? It's really a lot of disorganization that's happening in your brain, and absolutely there are patients that really benefit from the menopausal hormone therapy form of estrogen or estrogen progesterone, and even testosterone. Even though it's not an indication for it, when patients go on it, they do have some more clarity from it.
When we come back, Dr. Rahman and I take some time to go through the treatment options and clear up the confusion.
For most of us who really manage menopausal symptoms, it's precision medicine. We're trying to treat the patient as a whole in their entirety.
The viewer in the morning really needs to have a good feeling for what it's going to be like for the rest of the day.
I've got 3 kids myself, so I set out their clothes Monday through Friday, which you can do too based on our 7-day forecast. The last thing that you want to have to think about is, what is my kid going to be wearing to school? What do I need in the morning?
Having grown up here, having spent about 30 years in this market predicting the weather, you not only get really familiar with the weather, but with the needs of your audience. And that's what it means to be the weather authority.
This weekend, kick back and catch up with Fox 32 on Fox Local. Recap the week's must-know news.
This weekend, you're going to be dealing with a lot of closures downtown.
Relive Fox 32's best.
He's not just coming at you, he's coming at you with something that he just caught.
Plus the latest political and sports buzz.
Is this a role that you like, kind of going on the attack?
There's plenty of excitement here.
Watch live or anytime on demand. Weekends at Fox 32 on Fox Local. Download now on these streaming services.
Now, let's talk about treatments. From hormone replacement therapy to testosterone, vaginal estrogen, and birth control. The options can really make a difference, but they're often surrounded by confusion and mixed messages. Dr. Rahman stresses that treatment isn't a one-size-fits-all. It's about what works best for you based on your history, your lifestyle, and your needs. So for this section, you're gonna wanna lean back because there's a lot to talk about.
For most of us who really manage menopausal symptoms, it's precision medicine. We're trying to treat the patient as a whole in their entirety and based on their family history, their current history and everything.
Let's talk about that and
Yeah.
pause and talk about hormone replacement therapy, because years ago people were told, oh, it causes cancer, and there were all kinds of things. What do you want people to know about HRTs now in 2024?
Yeah, in 2020. Yeah, and there's so many clinicians who are still practicing like it's 2002 when the Women's Health Initiative is what you're referring to, which is really the largest study on menopausal women. It was a study that used a certain type of estrogen and progesterone that we actually isn't the most common type we use, the Premarin, which is the estrogen only pill, and then the combination Prem Pro. So it was a type of progesterone and estrogen that were commonly used for the longest time. And they're probably the most studied, honestly. There was the Women's Health Initiative that stopped in the middle in 2002 of July, and there was big announcements in the media that there's an increased risk for cancer related to this. And although it did demonstrate a small increased risk, it wasn't this huge number, and actually people that were on the estrogen alone really had a reduction in breast cancer. So 30% reduction in breast cancer. So it was really the progesterone in that was the enemy, I guess you would say. Certain types of synthetic progesterone does stimulate the breast tissue. But it was really a blown out kind of thing, and the Menopause Society, which was formerly the North American Menopause Society, has put out a position statement on hormone therapy, the safety, the efficacy, and who can and can't use it. And so a lot of that was really blown out of proportion.
So when you start the vaginal estrogen, you just stay on it?
Really, yeah, it's till
the
death
rest of your life.
As one of my friends, Rachel Rubin says, till death do you part. She's coined that, but I think that it's very true. Like I always say to my patients, just consider this your new nighttime regimen. Brush your teeth, wash your face, put something in there. It's gonna just all, and then if you're using systemic estrogen, you take your oral progesterone and you use your patch or your gel. Vaginal estrogen, there's a lot of ways that we can give it. We can give it as a cream, we can give it as a ring, we can give it as a tablet, we can give it as a suppository. You can even take an oral medication that really acts only on the vagina. It's called ospemifene. And it can actually, for patients that don't want to put anything down there, you can take something orally to help down there as well in the vaginal tissue. If you're in that perimenopausal transition and all of a sudden you're having all these symptoms and you're sexually active and you need birth control, sometimes going back on a birth control of some type, a pill, a ring, a patch, whatever, can be beneficial for these patients. And most of the time you have to take it continuously where you're not giving yourself that placebo week, right? Because that's when the symptoms might recur. So sometimes getting that standard amount of hormone, and then you get the benefit of contraception, because I have a lot of midlife patients who come in after a miscarriage because they didn't think they could get pregnant at 45 or 48, or they all of a sudden want to go have a termination of their pregnancy because they're in a situation where they didn't want or desire a pregnancy and didn't recognize the fact that they still have, some good eggs in there that might produce, just like a big shock to a lot of patients. But, so there's that option, and it really is a personal, some patients are, I don't want to go on birth control again, no way. And so if it's like a bleeding issue surrounding that, sometimes we'll do an intrauterine device, like a progesterone intrauterine device, add on like menopausal hormonal therapy in the form of an estrogen pill, patch, or gel. And then my favorite is vaginal DHEA, by the way.
Yes.
Yeah.
Let's talk about that really quickly.
Vaginal DHEA, the trade name is Intrarosa. I'm not sponsored by them. I just like the product.
Yeah.
I have to say that. But it's a suppository that you use in the vagina. It converts into estrogen and testosterone in your tissue. It feeds that opening of the vagina, the vulvar vestibule, and people get really maximum benefit because you have testosterone receptors down there too, so you're getting two for
And
one.
how often do they take that one?
That one is usually nightly. Some people rotate and maybe take it a couple times a week, but it is supposed to be nightly.
And how long does it usually take if someone starts HRTs to start really feeling the benefits of it?
It kind of depends on what symptoms you're looking to see a benefit of. The vasomotor symptoms, night flashes, night sweats and hot flashes, it can be within a week you feel them. You feel like, really better. I used to see patients after about a month to see how they're doing, and most of them are sleeping better, less or no vasomotor symptoms, and maybe improvement in cognitive function, but they're not 100% free of brain fog and that kind of thing. That takes a little more time, I think. And if by like 6 to 12 weeks you're not feeling significant improvement in that anxiety, I usually prescribe male testosterone and just have a patient titrate it to female dosing. You have this testosterone gel that comes in these packs. And a man will use one pack, on the back of their shoulder to replace testosterone once a day. But that one tube for a female should last about 10 days. So we use like a pea-size amount or half a cc of it on the back of your leg, every day. And basically a 30-day supply for, a man will last a woman 300 days. So almost a year. So again, it's not covered by insurance, so then you can get at least the benefit of using that 1 month supply to get you through almost a year. There is no FDA-approved testosterone for women in any country except Australia.
Wow.
Even though we have decades of studies that promote, and there's been all these introductions of patches and gels for women that just never got approved by the federal government.
I've heard of something that has become a little bit popular where you're putting pellets under your skin. Can you
Right.
describe that? And so some people are like, my desire just went up a lot.
I know.
So what are these different kinds of things?
Right, and most of us that practice sort of evidence-based medicine try to stay away from pellet form of therapy or injectables because what happens is you get a super physiologic dose of testosterone, right? If you pump someone with that much testosterone, they're gonna feel good.
Yeah.
And they're gonna wanna have sex, like that's just it. Like you're gonna have all this energy, you're gonna wanna go like, have intercourse with the person that you love or someone you don't love. I don't know, like you feel really good on it, right? People that's why it's really hard to talk patients out of using it. Because it is really these really above the physiologic range of what we see.
And that's what the pellets are?
The pellets, yeah.
Oh,
and
they have testosterone in them.
Yeah. Sometimes they're a combination
I
of things,
see. Okay.
but the ones that most patients seek out are the pellets with testosterone, and that can be dangerous. There's virilizing effects that can happen. A deep voice, facial hair, acne. Wow. All of these things that can sometimes not, especially the deep voice, they're not reversible, right? So, and then there's some patients that start having abnormal bleeding from it. They also end up getting these huge boosts of testosterone, and then they feel crappy at the end. And then, so it's really a roller coaster. A lot of patients when they stop it, they're like, it was just a big roller coaster ride for me. I was feeling great, and then I felt crappy, and then I felt. So it wasn't consistent with what's happening to them physiologically.
When we come back, we uncover why the conversation around menopause is so quiet and where to turn for quality information.
The social media role of what we do here is really vital.
My favorite platforms to be able to connect to the viewer is really Instagram, Facebook, as well as YouTube. I try daily to post updates. I really think Instagram is helpful. We can send out stories that are up to date.
We have to meet our viewers where they are, across all platforms, across all media.
Using every available tool to get important weather information to you. That's what it means to be the Weather Authority.
This weekend, kick back and catch up with Fox 32 on Fox Local. Recap the week's must-know news. Relive Fox 32's best, plus the latest political and sports buzz. Watch live or anytime on demand. Weekends at Fox 32 on Fox Local. Download now on these streaming services.
Even though menopause is a natural part of life, finding the right education and care can seem impossible. Too many women are dismissed or misdiagnosed, not because doctors don't care, but because they don't always have the time or the training to fully address menopausal symptoms.
It's a real black hole in the medicine world, actually, and we're trying to change that. I used to be in a busy academic OB-GYN practice when I still practice obstetrics. And if you're seeing 30 or 40 patients a day and you have someone in midlife in this crisis situation, you can't spend the time that you need with them to kind of tell them, really get to the bottom of what's happening. A lot of patients get dismissed. There's a lot of gaslighting stories on social media, and I'm sure any of us that have been in that situation have been a victim of that at some point. And it's a real problem within the system itself. And I don't think most of the clinicians doing the gaslighting are purposely doing it, honestly. But I feel like what happens in training is that, you get a lot of obstetrics, you get a lot of gynecology, abnormal bleeding, but sexual dysfunction, menopause management really get put on the back burner. And it's not just an OB-GYN study that came out showing, talking to family practice, OB-GYN and internal medicine residents, and what their comfort level was in treating patients coming out of residency. And it wasn't a lot of people surveyed, but the consensus was about 6% of graduating residents felt comfortable, whatever that means, prescribing or taking care of a midlife patient. So this is like people that are going to be your cardiologists who need to know about hormone therapy. Every specialty should really know about what's happening in this menopausal transition. The onus should not be on your OB-GYN only. So I think that's one of the problems in the system too, is that, your OB-GYN should have handled it. Yeah, a lot of us do handle it, but a lot of us can't handle it either,
Yeah.
But I think once I started my own practice in September 2014, it'll be 10 years in
Congratulations.
Thank you. When I started my practice, you see your first patient, you spend all the time in the world with them because you don't have that many other patients. But also because you're able to really get an in-depth history. And that's what kind of propelled me to get more training, because I had these patients I would see and I would be like, wow, I don't know, I didn't get that training. Let me go back to the Menopause Society and take a look. Let me go to the sexual medicine societies and see what's going on.
Navigating menopause can feel overwhelming, but one of the best tools you have is yourself. If you feel surrounded by conflicting information, trust what your body is telling you. Dr. Rahman encourages you to ask questions, seek second opinions, and find the resources you need to get the care you deserve.
I always tell patients to trust themselves. Like, your body. I know the science and I know the medicine, but I don't know your body as well as you do. Nobody's going to save you. Nobody's going to do it for you. And the system is rigged against you. So, you really have to be willing to just say, okay, this is my understanding of what's happening. These are my symptoms. If you're in a practice where, for instance, you see only pregnant women in your room, what is it called, the waiting room?
Yeah.
Maybe, unless there's one person that's designated as the menopause doc, maybe that's not the right practice for your actual treatment. Go to the Menopause Society website, see who's available in your area that's certified in menopause treatment. Go to the International Society for the Study of Women's Sexual Health website and try to find someone that's really interested, invested, and trained in this. Knowing your symptoms and knowing what your body is going through, there's no reason to suffer anymore. Mm-hmm. It's kind of like when you go into labor and you have those patients. I remember being an OB-GYN and patients would deny themselves the epidural.
Right.
When I got mine at like 3 centimeters and I was sleeping through labor, and I was like, why would anyone deny this?
Me too.
I
know.
Right? But like, why? You don't get a badge of honor for suffering, right? And at the end of the day, like, most of us don't want to end up in a nursing home, like,
miserable.
Peeing on herself, like
Right.
breaking bones left and right. Menopausal hormonal therapy really helps to protect your bones. And what happens to someone who's 80 who fractures their hip? Their mortality rate within that year is like 30% or something crazy like that. Like, it's really high. These are things that we can do to prevent. Like, we need to prevent stuff from happening. And I think that needs to be really the focus, right? And if you're already feeling bad and you're not feeling like yourself, which is a common symptom of perimenopause, just not feeling like yourself. Find someone that can help you, that's gonna listen to you.
We think that this is something that affects just old women. We've been, society has told us when we get to be old, we should just sort of putter away. We should fall off into obscurity, and that our issues don't matter. Well, that's just not true. I am going to be 58 years old this year, and I have never felt better. I have never felt more ready for this world.
Halle Berry's speech brought attention to these issues as part of her support for the Advancing Menopause Care and Midlife Women's Health Act. That legislation, supported by Senators Patty Murray and Lisa Murkowski, is pushing for $125 million in federal funding to support clinical trials, public health, and research on menopause. Dr. Rahman has been a leading voice in this effort. With more than 19 years of experience, she's a trusted expert. You can follow her on Instagram at GynOGirl or check out her podcast, GynOGirl Presents Sex, Drugs, and Hormones. This has been the Menopause Manual. Thanks for reading along. I'm Dawn Hasbrouck.
Being the weather authority isn't something that I take lightly.
When you're the authority, people count on you.
And in Chicago, of course, the weather can change like that.
It's about getting on the air fast when there's severe weather.
Among the tools at our disposal now is the ability to really look into a storm,
We now have the technology to be able to get down to that street level.
to be as precise as possible.
Accurate, clear, and immediate delivery of severe weather forecasts. That's what it means to be the weather authority.